Hello, I'm Ron Erbrick. I'm one of the adjunct instructors with Bevel State. I teach at Corner High School, the basic EMT program. Today we're going to be talking about abdominal injuries. This is chapter 30 in your book, specifically page 1071. And in particular, we're going to be addressing the abdominal evisceration today. So the abdominal evisceration happens when we have intestinal or fatty material protruding from the abdominal cavity. Now that can happen from multiple different injuries, traumatically, but in particular maybe a gunshot wound or severe traumatic injury like a car wreck. So we're going to talk about how to treat that. So when we come up to our patient, right, we address the patient, we've gone through our primary survey and we notice that we've got intestines protruding from the abdominal cavity. So one of the things we want to make sure of is that we don't palpate on this, right? We're not going to touch it with our hands. We're not going to put pressure on it. We're not going to push it back inside the abdominal cavity. We're going to leave it protruding. As we remove the clothing from around it, when we remove the clothing, we want to make sure if there's anything stuck to it, any dry blood, we're going to leave that attached. We're not going to pull it away. So then we're going to cover this with a abdominal bandage. So we'll take it out of our package, right? And then we're going to moisten this. We're going to make sure this stays wet. So we can use normal saline or we could use a sterile water, either way. So we're going to open this up and we're going to soak this pad with the saline. And then we're going to drape it over the top of the evisceration, the protruding intestine. Then we're going to take the packaging that the bandage came in and we're going to make an occlusive dressing out of it. So we're going to take it and place it right over the top of the moistened dressing, and then we're going to tape it all the way around. Our tape, and we're going to tape all four sides, sealed up nice and tight. What we're doing here is we're creating a barrier to keep any kind of debris, any kind of air, anything from getting into the peritoneum right there. So after we've done that, we're going to make sure the patient stays in supine position. We're going to look for signs and symptoms of shock. We're going to keep the patient warm, high flow O2, and this will be a priority transport. They'll need to be load and go.